We're going to, then instead of median nerve is here, right? Ulnar nerve is going to be here. So now we've got forearm pronation. So median nerve is forearm supination extension. Ulnar nerve is forearm pronation extension. So again, just remind yourself by doing this. You know, a lot of times you'll do that. Like the patient's in the room behind the curtain, you're kind of going, and then you go in and you act like you've been doing it forever, right? But really, you were just kind of, you know, testing it in advance. So sometimes you got to do that just to kind of remind yourselves. It's like the P&F patterns, you know. Right, so you kind of got him here, and it's really the same as median nerve. The only difference is you're here. So I've got the same situation going on. With this one, we want to make sure we're capturing the pinky and the ring finger. That's where that ulnar nerve goes. So we have an abduction, external rotation. We bring them up, scapular depression, forearm pronation, wrist and finger extension. Right? And now instead of extending the elbow, I'm going to start with the elbow straight, and I'm going to slowly flex the elbow. So this is what's going to pull on that ulnar nerve. So we bring it in here, and he says, oh, that's it. Okay, we're at 110 degrees of elbow flexion. Okay, so you're going to start here, and then gradually flex in. Okay, do the same exact thing with the head position, you know, sensitizing maneuver, just like we just did. Okay, so scapular depression, we're in here like this. We bring him into forearm pronation, wrist and finger extension. I have him resting on my leg. I bring him up into abduction, a little bit of shoulder external rotation. Right? And then once I'm here, then I start to gradually and very, very slowly, I try to see at what point his symptoms come on as I flex his elbow. So again, the elbow is what I'm playing with. It gives me my ability to kind of quantify the range at which symptoms come on. Okay? Treatment's the same. Hold it for a second, release, or hold it for longer periods, or kind of do some flossing. It's harder, right, to do that. We can certainly do that as well. I've seen people kind of get a positive sign, you know, here on this, and then they send the patient home doing these. You know, and again, this nerve is very irritable, so a lot of times I don't trust the patient yet. You know, like, because if you tell a patient, some patients, you know, to do 5 of something, they'll, you know, and hold it for 10, they'll hold it for 30 and do 30, right? So they'll do more. And with this, I could set you back for 2 weeks. I really could. I've seen it happen. So I kind of play with it a little bit with the patient first. Once I'm confident they understand what's going on, and I scare them enough, and I say, okay, here we go. You know, these are you know, begin trying these at home. All right, I'm going to show you the radial again, and we can kind of work on both of those together, or the radial as well, rather. So you can work on both of those together. The radial is a little bit different, and I've found that the radial actually is better to quantify at the shoulder, just because based on the position I'm in. But again, these are just suggestions. You guys can kind of figure out what works for you. With the radial, I'm going to now, instead of, you know, so the other two I was facing the patient's head, right? So with radial, I'm going to face the patient's feet. And I'm going to have them lying diagonally so that their shoulder is slightly off the table. So they're kind of laying like that, okay? What's going to provide the scapular depression is my leg. So I'm going to actually do this and provide that scapular depression right here with that. And now I have both hands to kind of work through this process. So what I'm going to do is I'm going to extend the elbow and I'm going to flex distally. So I'm going to have him right next to his side, but I'm going to start off with the distal component recruited. So I've got elbow extension and I've got wrist and finger flexion. What I'm going to then do is I'm going to slowly bring him into abduction. Now I'm looking at the shoulder joint as being the joint that's going to tell me when those symptoms come on. So if I'm here, 45 degrees of abduction. Right? Or if I'm here, you know, I gradually increase 70, 80, 90. Oop, right? I'm not paying attention. So definitely keep me from hurting. All right, so I'm in this position and I'm recruiting distally, and then slowly I'm just kind of bringing him up into abduction. He's internally rotated at the shoulder as well. And I'm just kind of measuring, you know, eyeballing the position of his shoulder is going to be the position I'm going to kind of look for. I can do the sensitizing again, move his head away or toward, and kind of get a sense of what happens with the symptoms with that. Yeah? So